So, a very good morning, a very good early morning. So, the panel discussion on EGFR mutant non-small cell lung cancer, and my first reactions in the morning was it's a boring one. I mean, I think from 2009 we have been discussing about EGFR mutant lung cancer, and it's very boring. You go and discuss gefitinib and osimertinib and stuff like that. My further reactions basically were आज कुछ तूफानी करते हैं. Let's just spice up the things a bit. So let me just stop over here before I begin my cases and ask everyone. Dr. Shekhar sir, I'll start. Dr. Rakesh Chopra sir, I'll start from you. What is the most tufani thing that you have done in a EGFR mutant non-small cell lung cancer? Anything out of the extraordinary or something?
Well, I am an old fuddy-duddy.
So you can't get away by saying all these things, sir. That is why you have the richest experience, sir.
Okay. Let me give everybody here, a lot of young people here, and I must give you the story of EGFR. EGFR, the first study done in the US on EGFR mutated non-small cell lung cancer adenocarcinoma was a negative trial. So AstraZeneca said that it is a negative trial.
Yes.
After that, there was a Lilly meeting at Kota Kinabalu. I don't know whether you people know about this place, but this is just off Malaysia, near Borneo, Sumatra, that area. Now, at that Lilly meeting, there was a young researcher who had just finished his fellowship from Canada and had moved to Hong Kong, and was sitting there at a table. We were all at a round table for dinner, and I had just done the first Eli Lilly meeting in New Delhi, and I said that, look, I've just reviewed the literature on non-small cell lung cancer adenocarcinomas, and we found that there are a certain group of patients who do well. So I said, look, why don't you look at this subset of patients? And you all know the story of the IPASS study, which he conducted and which has made him world famous today, because he found that in women of Asian ethnicity, adenocarcinoma non-smokers, they did very well with EGFR, anti-EGFR therapy with gefitinib, and that is the story of how gefitinib started. But having said that, as we all know, when we started the story of gefitinib, after that came the resistant forms, the T790, the R858, 858, am I right?
L858.
858, and now the mutation 20 again is the new thing, and then also there are also situation where now they are having the unknown forms of mutations in the EGFR. So EGFR is now unraveling into a very a domain where it's not so easy and not to be taken for granted that gefitinib is working, because you know that there are now resistant forms coming up. And I'll give you a story of a young man. He's just 35 years. He was in the United States, and he turned out to have a metastatic non-small cell adenocarcinoma with non-smoker with 20 mutation. And we lost this boy within 4 months. It was such a rapid, rampant disease course that you can imagine. So, it is not so easy. You cannot take EGFR for granted. You have to do further workup on these patients.
In fact, I do have that letter from AstraZeneca. AstraZeneca had sent a communication saying that gefitinib should be withdrawn and it should not really be given. Atezolizumab has been withdrawn for triple negative, and I think olaparib has been withdrawn for say third and more lines of this. And similar letter is there, and I do show in a lot of time that how times change. So from withdrawal of gefitinib in lung cancer to osimertinib everywhere. Patil sir.
Just as you are asking, any experience like that? Basically, my first patient what I saw was from a village. They brought in a stretcher with extensive skeletal metastasis, a small lung lesion. So a biopsy showed adenocarcinoma, and at that time we didn't have a method for detecting this EGFR mutation. So empirically based on the female non-smoker we started. Within next month she came walking, and 5 or 6 years this patient survived. She died of something else rather than that one. Like that, we have got anecdotal experiences of initial.
I still remember, sir, in 2009 when I finished my DM in 2008, this EGFR testing was not being done over there actually. So I had gone to Australia. Nimit Singhal was there. He was my senior from Kidwai. And we used to send the blocks over there for EGFR mutation testing. And it used to cost 45,000 rupees. And then the patient had to transfer money and the report will come in 1 month's time and stuff like that. So it has been a very good journey. Dr. Vinayak, anything Tufani? I mean, Tufani and Bangalore will go together, no? Anything in boat you have gone over there?
I think it's a small part, but I think the response, initially I can also quote an incident because my senior topic was Jeftinib and I used to give for all the patients, and since 2009 to same time, I used to never believe in Jeftinib, like he was like, it's acha response hai. I was like, I say fake re. But today, we are over, like now Jeftinib, we've gone beyond that now. Osimertinib is so smooth.
Yes.
And even it gives patients so clear, even generic works. So it's amazing.
Yeah.
I think with all the medical oncologists sitting here, I'm the only radiation oncologist.
So your work has become lesser after osimertinib has come. Your work has become lesser after osimertinib has come.
So I do practice as a clinical oncologist there.
Okay.
So I've done FRC here as well. So I would say something. So last year towards the end, I came across a patient, EGFR mutated, been on erlotinib for last 2.5, 3 years. At the outset, he was diagnosed with multiple brain mets, localized lung primary. He was controlled for 3 years with erlotinib alone after whole brain radiotherapy. And when he came to me, there was on restaging PET CT and MRI, there was a solitary progression in right cerebellum and a slight progression in the primary in the right upper lobe. So T790M was negative. So we decided in our tumor board, we treated that solitary brain lesion with stereotactic radiosurgery, and we treated the local area with radical RT. And it has been 1 year now, patient is under control and only on erlotinib. So he kept the patient on erlotinib.
I will show you a case, and it's the second case that I will show you across over there, sir.
So nothing too funny.
Nothing too funny. All dry shades over here.
I had one patient who was EGFR negative. All moleculars were negative. So he was on first line chemotherapy, came to me around 2020 or something in the month of August at that time. So first 4 cycles pemetrexed, carboplatin, followed by 4 cycles of maintenance, and then the disease progressed and was put on docetaxel for 3 cycles. After that it progressed and the patient's GC was not so good, so I put him on compassionate basis erlotinib at that time. And the patient is still maintaining a good performance status with a good
so I think all of us have patients which we have given up and they are doing good, which actually make us feel better actually.
Yes, it's
so
around
This is the one example where you give a drug, a patient gets a rash, you don't withdraw the drug unless of course this was a new learning curve at that time, because prior to this we were told, look, if you give amoxicillin, person gets a rash, stop amoxicillin. So this was the first incidence where we had to continue the drug unless of course it's grade 4 toxicity or something.
Yes, Chandrakanth.
So we come across instances where patient is PS3, 4 and we don't have a biopsy. At least we have a biopsy, let us say, and the TAT for at least 7 to 10 days elsewhere. So am I justified in starting a TKI, and am I justified in starting osimertinib based on this? I mean, PS3, no biomarker, the probability female, let's say, so it is fitting.
So I think Dr. Parekh would be the right person to say. You put, it's not that we have not done it. Normally I don't, because we have a liquid biopsy in our center, the report of which can come next day. If you cajole the molecular oncologist, the report will come the same day. But if you don't have, you write in view of the patient being sick, PS3, PS4, in the interim while awaiting for the EGFR test to start Jeffertinib. Osimertinib, the only issue is, Jeffertinib 5,000 rupees, people will not really bother. You give a medicine of 1.2 lakh empirically, that just might be an issue. So why gefitinib and osimertinib, why not alectinib? So it's always a cost issue also. So I think yes, we have done that. I have done that, but you document them right and you take a patient signature that we have sent the report, patient is sick, in the best interest of the patient, in good clinical faith, we are starting that. That's what you should do. That's what I do. Okay, next let's start with the case. Tufani to ho gaya. We have a 45-year-old male who was a never smoker. He was detected to have a lesion in the upper lobe during COVID. I mean, a lot of people have got lung cancer. The surgeons have been very happy with COVID. So many CT scans, some nodules have been picked up over there. PET CT shows a localized disease. MRI brain was done, which was NAD. Underwent surgery, PT3 N2 M0. Let the radiation oncologist not ask me why a CT-RT was not done. Ab to ho gaya. Patient was seen by a surgeon. Surgery has been done. Got 4 cycles of chemotherapy. Pemetrexed cisplatin. He is an EGFR mutant, del 19. And a PDL1 of 70%. So my first question to, let's say, Dr. Vivek, to you only is, do you ask for EGFR testing in resectable early stage non-small cell lung cancer?
I ask for all, irrespective of stage, I'll ask for all lung.
You ask for all. In stage 3 also you ask, in stage 1, 2 also you ask. And why do you ask?
First thing is the biology. At the end of the day, it's marker of the biology. And
Okay.
first and second, when we have progression or sometimes patients prayers will not be good enough. So your option should be ready, because so many times it happens that every time we have a diagnosis of lung cancer, we struggle for a report. You don't struggle, I know that within 24 hours you'll have the report. For us it's a struggle for at least 2 weeks. So we have to have that option to start early.
Okay. So you do send EGFR test?
No. All panel, I said the lung whole panel.
All testings.
Yeah, I think we've got now adjuvant EGFR TKI data now, and the patient underwent surgery. It is worth getting the EGFR done.
So you are getting your EGFR testing done. You are getting EGFR testing done. Okay, fantastic. So the patient has got a PDL1 70% and the patient also has a EGFR mutation del 19. Common, uncommon in your setting? Does it happen? It happens very regularly. I mean, if you start sending for all, it happens very regularly. It is not something which is this thing. So, what is the opinion regarding the further management? First, I'll ask about radiotherapy. I think, I finally saw you guys' name and said, okay, fine, there should be some question for radiation oncologists also there. So, this is just a last afterthought I have put across.
So the indication for radiotherapy in post-op setting is either margin positive disease or N2 disease. Lung study is showing some benefit.
Or an N2 disease. You don't believe in lung art nowadays? Lung art trial did say that there is no benefit of giving radiotherapy in a post-op N2 disease also.
Yeah, that is debatable. That's
That
another
is
debate.
debatable.
Yeah.
Okay. I think we were at our
Only proper indication, I mean definite indication is margin positive disease.
margin positive, yes. I mean, I agree, and I think the radiation oncologist in JP Agarwala is not there, the other center. But I mean, the radiation oncologists also have started to cut down, at least in our center, about the role of post-operative radiotherapy in a resectable, because the toxicities and all are actually overwhelming over there. Which brings us to the next question. The third one is easy: adjuvant immunotherapy. Dr. Shekhar Patel, sir. The third one, immunotherapy.
No immunotherapy.
Okay, then let me go to the more difficult one. Whether you adore the Adora or you don't adore the Adora. So, will you counsel your patient for adjuvant TKIs?
So yes, sir, I will counsel the
We
patient.
will just say yes right now or no right now, and then we will move on. So, one yes.
Yes. Yes.
Yeah, what were you? Yes.
Yes.
3. Dr. Chopra, sir? Yes. Oh, we have a 5-on-5. Yes, fantastic. None of us listened to Sanjay Popat's commentary about adjuvant Adora and ESMO. It was none of us read the tweets which were given by Amol in the WhatsApp groups. So we will go to it now. So this was basically the adjuvant osimertinib in resected EGFR mutant non-small cell lung cancer. Some of the very important fact in the clinical design over here was patient could have got chemotherapy, patient could not have got chemotherapy, because right now what is happening is people are just saying, okay, fine, EGFR mutant is positive. The trial was positive for with or without chemotherapy, and they are actually discarding chemotherapy out of it, which I think Vinayak is absolutely right in saying don't do this. Chemotherapy will remain an integral part. TKIs are only going to supplement, complement, and not replace chemotherapy in the adjuvant setting, because that is the only way a cure can be achieved. The second question over here, Dr. Tanmay, which I'll ask you was 3 years of adjuvant osimertinib. Now, where did that 3 years come from? Any ideas on that? I'll share with you an interesting story. Anyone can tell about 3 years? Okay. So what happened over there was the Radiant and the adjuvant trial were trying it for around 2 years, and suddenly these guys took inspiration from adjuvant imatinib in GIST. That was for 3 years. So they said kuch to karna hai, so let's keep it for 3 years. That is as plain and simple as that. There is no science and rationale. And again they saw that when you give adjuvant gefitinib or lorlatinib in 2 years, the relapses were occurring in 3 years. So they thought, okay, fine, let's give it for 3 years and then see what happens. Imatinib also works for 3 years, so that is how they had to give a number. So there are two important things. One is the completely resected non-small cell lung cancer. Second is the 3 years of this. Now this were the results at ASCO 2020, and this was the results which was basically shown. Impressed with the results, I guess all of you? Dr. Patel, impressed? Everybody impressed with the result? Fantastic. So all of you will agree to give adjuvant osimertinib if a patient is, I'm again asking you, if a patient can afford, we will be happy to give adjuvant osimertinib. Fantastic. Now what happened is, which happened around 2 weeks back, was ESMO 2022. And this is the graph which Sanjay Popat, the discussant for this long term guy said. And he said, okay, stage 1B, the graph is actually going straight over here. But if you are stage 2 and stage 3, the moment you stop osimertinib, the graphs are actually coming down. So the same thing which happened with adjuvant gefitinib and erlotinib, the same thing that you basically stop the TKIs at 3 years, the graph is actually coming down and people are relapsing more. Now tell me, hot or not? So you read his commentary also over here, and he basically wrote that, for stage 2A or 3A, are we only delaying the inevitable? There has to be a time when you will stop osimertinib. I mean, you cannot give it for eternity. So that is why I said initially that, you cannot, you're only delaying. Are you curing the people? So curing the people is what chemotherapy does. You give 4 cycles of chemotherapy, people get cured. You don't give chemotherapy for 3 years. But since it is a cytostatic drug, are we only delaying the inevitable? And the OS of ADAURA will be presented at another 1 year or 2 years, and 2023 is where it is expected. And that is where we will discuss. Now, the other dilemma over here, Dr. Tanmay, I'll start with you. The DFS data was there, the OS data is not there. Why don't we want to wait for the OS data? I mean, that's the dilemma which is already there, I mean, should we wait for DFS or OS?
So we should, based on the DFS, we generally give it nowadays. But yes, we should wait for the OS data also, because that's also important.
Okay. Sir, Dr. Yeah, please. Animesh, yeah.
Yeah. I think we will have to look at the OS data as well. But based on the impressive DFS data, we should try it.
You try it, okay.
I think OS will be good because there's no second salvage options available. But I think in adjuvant thing, DF is okay.
DFS is reasonably okay. Such
okay.
a good magnitude of DFS is also okay.
Yeah.
Dr. Shekhar Patel, sir?
I think DFS with such a wide, the graph was so good in the initial phase. We were very impressed, and I think that was the basic reason that we used to start for all the people who are eligible. But now, but seeing this one, we feel that we have to wait for the OS
So
data.
this was the DFS versus the OS dilemma. DFS endpoint is something which is easily available, early availability of the results. Patients may not have to wait for long. So, today if you have a DFS advantage, and it did turns out to be having an OS advantage in 5 years time, and you don't give, you wait for the OS. What about the patients who lined up over here? That is the problem. But it is not the gold standard. In the curative setting, it may not translate into an OS advantage. And this is almost like, are we actually for Donald Trump lowering the bar? I mean, initially we started looking at the OS, and now we're looking at the DFS. We see it in all the advantages. In the curative setting, are we going to wait for the OS is something? Having said that, I mean, the most important example which everybody gives is in adjuvant hormone therapy of breast cancer, everybody uses AIs. Has there ever been an OS advantage of AIs over tamoxifen? And the benefit at 8 years also is 1 to 2%. And I absolutely love a comment by Sudeep Gupta sometimes. He said, the more I use AIs, the more I like tamoxifen. Because there is no side effect, there is nothing over there. So, I mean, are we lowering the bar? But the point is, lung cancer is not breast cancer. Lung cancer is a very menacing disease. It doesn't really give you time on that. So, This is the crux of the debate actually. Yes, you have a point, yes.
So I just want to ask the panel and yourself. So suppose there is a patient who has underwent surgery and the notes are like N2, N3 suppose, and osimertinib definitely is, we
2
are not
minutes.
yeah.
Have a seat. 2 minutes. I have that question.
So yeah, I know. I'm asking, is gefinib an option in that case?
2 minutes. 2 minutes. I knew this will come. So I am prepared for that question. So the crux of the debate basically between the DFS and OS is the people who adore Adora, people who are adoring Adora over here. Not that I don't adore Adora, because I feel that people living without disease also is a very important thing. You know, living with relapse and living without relapse is also something very, very important. And a lot of people will not take TKIs at the end of it. So that is also a point. So adorable Adora, you give surgery, chemo, TKIs, some of them relapse and then they get a standard of care and then they die. Vis-a-vis, you give surgery, chemo, you wait for the relapse and then the osimertinib further treatment death. So if these two are equal, absolutely, then there is no point of giving this thing earlier. But if one is better than the other and if the other is actually better than the first one, let's say if this actually turns out to be lesser, that will be a huge turning point in the way we will look at the things. So what will we choose? We don't know. When the Adora trial came, I was a big proponent of Adora, but after this year's ESMO 22, when it is actually coming down, I am beginning to realize two things. A, I will never withhold chemotherapy from my patients in adjuvant setting. Those 4 cycles of chemotherapy are a must. Osimertinib, I will actually, so you know who said 3 years? Don't we give tamoxifen for 5 years? Don't we give tamoxifen followed by AIs for 10 years? So if somebody is living without disease, a T3, N3 or T3, N2 disease, may be tempted to give in stage 3 disease. Stage 2, stage 1 disease, my enthusiasm actually coming down at that time. That is what I would probably do. So what will we choose? We don't know, and this is for Dr. Chopra sir. Sir, what will you do? Money, luck, love? Sorry? What will you choose? Money, luck or love?
Well, everything has its own
Sir,
pocket.
you can't be politically correct all the time, sir. One you have to choose. You and then Shekhar Patel, sir.
I think I would go by luck.
Money to aapke paas hai, sir. That's absolutely all right. So I knew this will come. I have an answer for the other one also. Dr. Shekhar Patel, sir.
I will go by the money if there is.
See, and that is why we are all here, sir. I have an answer for everything.
You know, as far as this question of whether DFS versus OS, if you remember, I mean, when we started oncology, the treatment was best supportive care, yes. And at that time the survival was 2 months.
Yes, sir.
You know, so taking a cue from that, at this stage, you are right, absolutely, that the curative intent would be chemotherapy if the patient is fit for chemotherapy. But in this situation, all the trials of lung cancer, because they needed to give results, they needed to get people to take those therapeutic things. That is the reason why DFS was the endpoint rather than the overall survival, because you could not wait for 5 years in this.
So what happens is, you know, people should not go away with that advantage. You know, sir, what happens with the younger, I mean, now that I can say younger generation is, you look at NCCN. I mean, this is exactly the opposite of the way our first year resident reads NCCN first, says it is approved, then goes back and reads the literature. That critical analysis of the thing, that thing over there is, you know, that Dr. Parekh was telling yesterday, people don't come over here. I mean, you know, that is the fact that I don't want people to go over from there, that, you know, you forget chemotherapy, just give adjuvant osimertinib. And now that when I counsel my patients, I actually tell them you may have to take it for a more time also. You're willing to take, see, today it is 1.2 lakh rupees. Tomorrow, if the same osimertinib 12,000 rupees, everybody will give. You know, the question which Chandrakanth asked was adjuvant gefitinib, I want bladder and eyelid. Because 5,000 rupees, 2,000 rupees, it's okay. You know, even if you do it, nothing really makes a difference. 1.2 lakh rupees, if you have to spend for the next 3 years per month, you would rather choose money over it actually and not the luck, everything actually. So, to answer your question, if osimertinib is not available, as the second question will come, everybody said yes to TKIs, you know, I mean everybody said we will give TKIs. So let us say osimertinib is not available, not affordable. So will you choose a first or second generation TKIs? And this is what I am saying. This is NACLC adjuvant. This is osimertinib. they are not there. Will you want to go for a first or second generation TKIs is what they are asking now. So let me start with from that side.
Sir, I will not be willing to give with first
You will
generation.
not be willing to give. Why you will not be willing to give?
Because as per
This is
the
a
trial,
trick question. I'm telling you it's a trick question.
sir, we got the DFS data from this Adora trial only. For that only the picture of osimertinib, the osimertinib came into this adjuvant
So
and everything.
you were giving osimertinib because of the DFS, no OS. I'll show you the data. Okay, yes, Dr. Saha.
Yeah, I am not aware of any other
You're
TKI
not
being
aware.
tested in
Fantastic.
adjuvant testing.
Dr. Vinayak.
The data is there for Japanese studies. There just came on just 1 year after that. Holistically, I would give for the TKs for same reason why I'm giving osimertinib. The catch in osimertinib is smooth. It doesn't trouble patients so much as your lutinib or for 3 years. So in a patient who's cured.
Dr. Shekhar Patil, sir?
I feel at least first generation, second generation, whatever adjuvant therapies, we know the overall survival advantage is not there.
Yes, sir.
At that time, we may not be right in using it. We can use it whenever the disease comes back. Okay. But in osimertinib, still we are not very sure about that one. All these days, we are very sure that OS will be definitely a positive.
Okay.
But we are slightly shaky now.
So
I think we have to.
answer your please. I'll both of you can come. So to answer this question, this is like a typical Delhi wala thing. No, hota hai, chalta hai, chalo kuch to de do karke. You have a point now.
Post surgery, I have a patient, 66-year-old lady. Post surgery, she had comorbidities, asthma, DM, and she was not keen for chemo. And she was EGFR exon 19 positive deletion, not for osimertinib. I have started her on geftinib. So is it a right way to do?
So it is not. So the point is, as long as what you tell the patient, you don't tell the patient this is a great drug. Usse bolo, yes, your disease-free survival can increase, but your OS may not change. So you cannot tell the patient this is the panacea for, this is not an option for replacing chemotherapy. And again, as we were discussing yesterday, document in the file that you cannot take chemotherapy in view of a high burden of disease, patient not being able to take chemotherapy, EGFR mutant positive. In spite of the not OS advantage, discuss the same, because this is still better than nothing.
Yes.
If you don't take chemotherapy of observation, this is still better than that. So yes, you can give, but again the documentation in the file will be there, because once you show these graphs, see what these graphs basically show is, there were 2 years there was a DFS advantage, similar to what there was there in osimertinib. In 4 years time there was no OS advantage. Now as Shekhar Patil sir very rightly said, there is no OS advantage in gefitinib. You may or may not give. In osimertinib, you are still not sure. You may or may not get. So you can go ahead with that, but document this in the file. You're not wrong, but there's not something, it always starts with this only. First it's a 67-year-old lady, then PS2, then somebody whose attendants are very iffy-jiffy. Then there, it starts, we all have seen, it all starts like this only. But you are right to do that.
Now, she has completed 2 years now. So what would...
Stop.
Don't stop, yeah.
I would not stop. I would not stop.
She's
I will
tolerating it very
tell
well.
them over there, somehow document over there that this is there. At 5 years, whether at 5 years survival of is good enough for them, it's absolutely okay. And again, document in the file, because you are not giving a standard of care.
One more question. Yes. The same patient, if he was he or she underwent CTRT, and at 3 months we have a partial response, what would be our maintenance strategy?
So we had a FLORA trial and we had a LAURA trial and nobody referred patients to us. 2.5 years with COVID, we were having a CTRT followed by adjuvant osimertinib for 3 years. We failed to get a single patient in that. The LAURA trial is there, the results will be out, but I have a feeling, that also is there. You somehow read my slides, I guess. What I would not do is, I will not give durvalumab to that patient. Yeah. What I would do is, maybe discuss with them about this thing. At present, we are not giving. We are keeping them under follow-up. We are doing a CT scans and MRIs very regularly and then treat them over there at present. Yes, Chandrakanth.
So, osimertinib versus the magnitude of benefit is better for osimertinib, number one. Number two, sir, is there any relevance of PD-L1 in EGFR mutant at any point of time?
No, nothing.
In later lines?
Nothing. Nothing. Period. I will again show you the data for that. So this is the data for adjuvant TKIs. I mean, you can, but there is no FDA approval. It will be difficult to, get out of that soup. Just in case somebody really puts you into a grade 4 reaction or Steven Johnson something over there, it will be difficult to get out of the soup on that time.
Just coming back to your comments, so are you saying, say, if there is any stage 3 non-small cell inoperable lung cancer, EGFR mutation positive, say PD-L1 positive, have CTRT, radical CTRT has partial response, would you give adjuvant durvalumab or adjuvant TKI?
I'll give nothing. That's what I'm saying. I will not give adjuvant. I have the slide over there. I will not give adjuvant durvalumab because it has not been shown to have benefit. A. Second, I will not give adjuvant osimertinib because there is no advantage. I'll keep them under observation. I will show you my slides over there. This is slide. That's why I said no. कुछ तो funny करते हैं आज. I will come and say I do not want to give EGFR TKIs in a patient who is EGFR mutant. You can argue it the other way. People will be lost to follow-up or something. But I have a different when there is no OS advantage in a stage 1, 2, 3 your aim is cured. I will let's go to the next slide. Sir,
I have a question. In patients who are say resectable, how often in this country do people do resection versus chemoradiation, concurrent CTR?
That depends upon where the patient does turn up into. So if it turns up to a medical oncologist or a
What
surgical
percentage?
oncologist.
What percentage of patients who are resectable would go in for surgery, and versus this in this country?
Dr. Shekhar Patel, sir, will you like to take that?
Maybe 50%, sir. Generally, we see
Not
with
all
the
surgeries, not all people will actually recommend surgery. But sir, now what is happening is the data for all the adjuvant treatments are much. The new adjuvant immunotherapy, new adjuvant osimertinib is also coming up. The data is now coming up more for adjuvant immunotherapy, adjuvant TKIs after surgery also. The people are, and the willingness to shift. I'll just, if you give me time, before you give, because I have some interesting questions actually coming ahead with that.
One question, sir. Just you told partial response after RTCT, you want to wait. I feel because there is a disease, you are not thinking in terms of an adjuvant.
So one second.
For that reason, I
think
wanted.
the question over there was CTRT. You have done CT scans. I think the most important thing will be evaluation was done at 6 weeks or at 12 weeks. If it is done at 6 weeks, you have still not given time for the drug to act. If at 12 weeks or at 16 weeks, so what we do is a CTRT, we don't evaluate at that time. If you finish on January 1, we'll do the scan on April 1. If on April 1 and May 1 also disease is positive, then we will say, okay, it's a palliative setting. But if you do it on February 6, that is what we do for durvalumab Pacific studies, and if the disease is positive, I will not act on that. I will say, okay, just relax. If I have a Pacific trial going on, which we have, publicity to karni hai na sir, Pacific 8 is going on, we will put the patients into that, otherwise we will not put it across. So, okay, we have a problem. Okay, so this is where EGFR mutant and PDL1 more than 50%, there is absolutely no advantage of giving adjuvant immunotherapy. You should, PDL1 has got no role whatsoever with immunotherapy, I mean with EGFR mutant, don't even think about it. ADAURA trial, what about the tolerability, what about financial toxicity? Very, very important. And again, if you see over here, 45% of patient diarrhea in 45% of patient, grade 3 or higher, paronychia in 25% of patient, stomatitis in 18% of patient. Imagine having a grade 3 diarrhea which is more than 4 to 5 episodes per day for the next time of this 3 years. Somebody sitting over here and has to go to the loo. I mean, you know, prostate is a normal problem. Having diarrhea along with that is also tough. And these are normal problems. This is not this thing. Plus financial toxicity. 1.2 lakh rupees into 12 is 25 lakh rupees into 3 75 lakh rupees. These are not small amount of money. So that is what. I will skip this. What about the uncommon and the rare mutation biomarkers? Osimertinib in this trial was only for 2 mutations. Yesterday only I got a thing. I have an exon 20 insertion. I have given 4 cycles of pemetrexed cisplatin. Can I give osimertinib? I said please don't. And please renew your professional indemnity also if you have given, because nobody will be able to get you out of the soup. So my conclusions on ADAURA, never seen before DFS advantage. The HR ratio of 0.12 and 2-year DFS of 88 versus 32%, fantastic. CNS recurrence occurred in only 2% of the osimertinib, fantastic. It reduces the distant recurrences. However, there is no OS advantage at present. That is something which needs to be understood left, right and center. Are we only delaying the inevitable? I think yes. So the next trial in my mind should be 3 years versus 5 years, 5 years versus 7 years. Also, I think here is where the role of a ctDNA and a MRD will come. If somebody is having an MRD negative at 3 years time, stop for them. Keep on doing the MRD at 3 years, at 3 years, and at 3 months, and then maybe reinstate something which they did in the Apple trial. Financial toxicity definitely is a concern. Tolerability for 3 years is definitely a concern. So these are the pros and cons of the ADAURA trial, which we need to discuss before we blindly put it across. And the more I read ADAURA trial, the more I like chemotherapy in the first line setting. That is something which is absolutely, absolutely not to be taken out. So there are two sides of the truth. This is the incident which happens at the academy. This is the, I think Will Smith was the guy who hit the other person, and this also is the truth. So it depends basically on, there's one truth on the left and there is one truth on the right. Which when you belong, time only will tell. But there's only one eternal truth, that if on Sunday I don't reach on time at home, I will not be able to allow to the next Sunday conference. 5. That is the eternal truth. So that is one for ADAURA. This is my conclusions on that. Now this is something which is very close to my heart, oligometastatic disease. So oligometastatic disease, and this is a real case which I also had presented at ESMO Asia 2 years back. This is where the role of a surgical and the radiation oncology also comes. So a 45-year-old female, never smoker, she does not have any other comorbid conditions, came with a history of convulsions. So since it was a convulsion, she went to the surgeons first, and Dr. Rakesh Chopra said it depends on which doctor does the patient land up into. Yesterday somebody was telling, a patient gets the doctor he or she does. I think Dr. Parikh said that. So MRI brain showed a single parieto-occipital lesion with perilesional edema. Rest of the brain parenchyma was normal. She was seen by a neurosurgeon, underwent excision of the lesion, HP deposits of metastatic adenocarcinoma, TTF1 positive. So this is what, since it was an ESMO Asia presentation, so I have the slides also over here, but we'll just go with. The staging investigation was done. There was a lesion over there in the lung, and this was the brain lesion basically, and this. So EBUS with biopsy revealed adenocarcinoma lung with N1 lymph nodes. Here is where I like to ask Dr. JP. Dr. JP sir, so as surgery has been done for a parieto-occipital lesion, and a patient only has this lesion, would you give radiotherapy to this particular, the lung lesion also, the brain lesion? And when will you give that?
Yeah, I think I will seriously do at least a chest X-ray before doing the surgery. She was a right-handed lady probably, majority of them, and there was a left-sided tumor. So I will be really cautious. We will discuss both the things. That needs to be seen somewhere. But since you have already done those things, I will radiate this, and I will be very cautious to look out before radiating this. I will again have a MR and all those things.
So MR says post-op cavity, nothing else. Will you still radiate this? That's what I want to ask.
Yes. So there is there are enough evidence that if you radiate this and this together, the likelihood that the recurrence will come here is much less.
And if the surgeon wants to operate this, and then what about this, sir?
Still, I will ask him to go ahead, knock it out.
Okay.
So a basic idea is good control both the places.
Okay.
That's the key.
So now, sir says he will radiate. Our radiation oncologist, we didn't allow him to radiate the brain. We said one modality has been given. So one surgical lesion, one brain lesion, surgery has been done. You have a lesion in the lung, for which it is a adenocarcinoma with a N1 or N2 lymph nodes, whatever. He was given 4 cycles of neoadjuvant chemotherapy with pemetrexed cisplatin. We can debate about why pemetrexed cisplatin was taken and why not nevilbine cisplatin, but I mean I am very comfortable using pemetrexed cisplatin, and that is what we all use. She tolerated well. Reval showed partial response to treatment. MRI brain said no positive changes. She underwent lobectomy and medicinal lymph node dissection. So you have now YPT2N0. It's technically not an M0, it's an M1 disease. So she was also directed to have a EGFR mutation L858R. So we'll start from Dr. Shekhar Patil first. Sir, brain lesion, surgery done, oligometastatic, surgery done for this.
Yeah, this oligometastasis thing, particularly solitary lesion in the brain or a solitary lesion in the adrenal gland, no? We look at it with a curative intent treatment. That is the first thing. And that is what exactly was done in this patient, and underwent surgery. And definitely I will give pre-operatively the chemotherapy was given. Now I will give some adjuvant osimertinib to this patient as I treat for any, as an adjuvant therapy like that.
Even after the ADAURA ESMO 22, you will still give ADAURA?
Yeah, in this patient I feel it may be
more convinced because brain mets was there. Fantastic. Vinayak?
Yeah, I agree with it because it may be pseudo-adjuvant. At the end of the day, it was metastatic disease.
Yeah, it's a pseudo-adjuvant, but it's not metastatic, right? The principles of a oligometastatic is you want to cure this patient.
Yeah.
So you will give.
I'll give.
Fantastic. Dr. Saha,
I think it's reasonable to give this patient EGFR TKI.
you will want to give this patient a EGFR DKI.
So it's, I will give this. But sir, I had one question, how long to give, whether 3 years or 5 years for this patient?
I will,
specifically?
you know, so there is a patient of mine which is taking for 3 years, 5 years, because, you know, whenever I say stop, it's technically a stage 4 disease. Anybody else, Chandrakanth, what is your take? It's grey, it's not white, it's black. So, yes.
I want to ask again a practical question. Is it, if it's not, osimertinib is not possible, can afatinib replace geftinib because it has better CNS
So
coverage?
this patient had come to me in 2018 and osimertinib was not available to that. And what did I do? I kept the patient under observation. I said it's an adjuvant setting, there is no OS advantage, and I said we will not give. And there was a lot of resistance from my colleagues, from my own department people. I said no. We gave the example to the patient and we told it's a curative setting, knew that adjuvant data had come. I said I will not give. Absolutely okay. For the next 15 months I was God. You know everything was going on fine. The patient was not recurrent. Every time she'll say साहब ने बचा लिया. And you know आप लोग तो दवाई दे रहे थे मुझे वहाँ करके आपने मना कर दिया. You know all those normal patient stuffs. After 15 months she came. She came with pain abdomen. Got a PET scan done. And the metabolic active mesenteric soft tissue deposit was there, and then she looked at me and like this, and if you could have given me the medicine earlier, ab to mujhe aisa na hota. I said whatever, you know, now though it is there, what can I do? So CT guide biopsy was done, which came as adenocarcinoma. Again EGFR mutation was done, which basically came as L858R. She was tried on second generation TKIs. I'm slightly fonder of a second generation TKI than I am of that. Responded well, reval showed a partial response, and this is what it was basically done. Okay, then basically patient had pain abdomen. So after 15 months she came, now she had mesenteric soft tissue deposit was there, we put her on to L858R. She had a pain abdomen, persistent pain abdomen after 10 months of that, for which she was investigated, and there was a ileocolic interception with lead point reaching at the region of hepatic flexure of colon. So she had a colonic deposit now. So brain, surgery, chemo, surgery, observation, metastatic disease, and then the patient has now come back mesenteric soft tissue deposit. Now she has a colonic deposit. Now what do we do? So what we did basically was, and this is what we basically showed, ascending colon lesion with significant luminal compromise. Yes, Dr. JP. Surgery. Haan, sir. So surgery. So this patient we had advised her surgery. She said, no doctor, what to do, why to do surgery, and every time, you know, patient becomes smart. First time some resident would have asked, motion pass हो रहा है, बोले हाँ, पेट में दर्द हो रहा है ना, उल्टी आ रही है, बोले हाँ पर हर रंग की नहीं आ रही है. So when you know all these things were there, she said, I don't want to do anything. Okay, fine. Every time I said, motion हो रहा है, हर रंग की उल्टी नहीं आ रही है, पेट नहीं फूट रहा, now go, give me medicines. Fair enough, she didn't want to get surgery. Finally she ended up like this and she underwent a hemicolectomy. Now at this time, biopsy was adenocarcinoma, TTF1 positive once again, and the biomarker testing was L858R, no T790M. Now what will you do? Will you give chemo? So there is no other disease in the body. Mesenteric soft tissue deposit was there, taken care of by lorlatinib or dacometinib. I think this is dacometinib. Then we have done the surgery, oligoprogression you can call it. We have done the surgery for that. So I'll start with you, Dr. Sanmay. What would you do now?
Chemotherapy.
I also did the same. Took a deep breath. What would you do now?
Chemotherapy.
Chemotherapy. Fantastic.
So I think it's oligoprogressive disease, and we have already taken care of the disease. So we can continue with the same EGFR TKI that
so one chemo, one same TKI. I have put no T790M, otherwise osimertinib also would have come into this.
Yeah, you wanted the same answers. So I think local therapy is done. So and you can give systemic therapy with TKI.
Which systemic therapy?
TKI only.
TKIs. So same TKIs, different TKIs. Just for the heck of it, change something. No, same.
There's no logic there.
No logic there. Dr. Patel, so 2 TKI, 1 chemotherapy.
I would change the TKI. I would like to go for osimertinib.
Oh, you like so this is why I feel, you know, I mean the tumor heterogeneity has learned from India. You know, we have different people over there, everybody will give things. So tumor has learned from India actually. So what we did at this time was, we continued the same dacometinib only because we felt, first of all, there was no T790M. Again, I think it was 2019, 2020, so at that time things were not even available at that time. So I said, don't change anything. We have treated it as an oligoprogressive disease and we will take care of the oligoprogression, and we took it like that. She got dacomatinib for 9 more months. So, you know, and now she has got a new para-aortic lymph node, no other site of diseases. So mesenteric soft tissue deposit, done. A colon, done. Dacomatinib continued. A CT guide biopsy showed adenocarcinoma TDF1 positive, para-aortic lymph node, a very small 1.5 into 1.5. Chandrakanth? And then Dr. JP. Dr. JP is already, you know, given radiation over there from there only.
So,
yeah, you smiled. I also did the thing. I also smiled.
I think
And the best thing which I tell them is, we will discuss your case in tumor board. This will give you 4 days of breathing time. And they now, you know what happened, these people know that tumor board happens on Thursday. They come on Thursday only. Okay, tell me.
So surgery, then chemo, then change TKI.
You will do surgery and then chemo,
and then I'll change after completing whatever 6 cycles.
You will change
I'll put an osimertinib. That's what
okay,
best
put
I can.
osimertinib. Dr. JP, what would you do, sir?
No, very simple. I need to control this disease, minimal toxicity way. So if it is radiatable with curative thoughts, give SBRT, otherwise take it out. But I want to ask something, Ullas. Will NGS previous time would have given you some big thoughts? What is the penetrance in that system, though your biomarker was positive? Is there anything else in the system which is simmering?
I haven't really thought about doing an NGS for her, sir. I think clinically she is doing fine.
I know that. What
so
I'm saying, academically, would you have done something at that point of time, because you would have got some more bands?
Maybe, sir, but I mean, point is that, you know, my point was I am not going to change her treatment. She doesn't belong to a very affluent family, so not really thinking in terms. We will do a serial NGS for her as a part of research project sometime, but not right now, present. So this case was discussed in tumor board, and EGFR mutant, no T790M mutation, in view of oligoprogression, got RT to the para-aortic lymph node, again doing on dacomatinib. This was 2 years back, slides, 2020 I think I presented in ESMO Asia, and she is absolutely fine now. My point over here which I wanted to discuss was not because kuch tufani karte hain, but basically because, you know, oligoprogression, and the more we are using TKIs, you know, in the tumor board, what happens is you have 2 medical oncologists, you have 2 radiation, 2 surgeons, 1 one interventional radiologist guy. In the end of this, we did an audit. More patients are being given to radiation oncologists and surgeons and the IR guys than they are being given to medical oncologists. So the role of local treatment actually has increased after you get them controlled. 100 times we have been giving RT to the oligoprogressive site, or, you know, surgery for these sites, and we're becoming more aggressive with this. So the better systemic control that we have, the better opportunities are there for the local modalities, other modalities also. Not because we want to give them business, because the patient actually gets benefited out of it. This is what our point of view is.
One important concept Dr. JP sir mentioned, that whenever a patient is progressing, whether it's oligoprogression or frank progression, ideally we should have a biopsy and check for new mutations, because it has been seen that patient might develop resistant mutation other than EGFR, like MET or ALK. And there are evidence that if you combine EGFR TKI with a MET inhibitor, you can control the disease.
We have both these trials going on right now. We have the trial of osimertinib ke baad mein savolitinib going on, the CUC Capitalo study, and we also have amivantamab lazertinib study going on. Point here is this is an oligometastatic disease. This is not a polymetastatic disease. Why I didn't do an NGS at that time, sir, once again, was because I will order a test when I want to change my treatment. If in an oligometastatic disease I am not changing my treatment, I don't want to do a test and, you know, complicate myself. Now let us say this patient had shown MET, then what was acting? Why give toxicity to that patient? So that was my thinking, but you're absolutely right in, you know, I mean, I'm a big proponent of biopsies, man. I mean, we biopsy left, right and center, everyone over there. A liquid biopsy or something of that. So Dr. JP and then Dr.
So probably you did every time brain MR.
Yes, sir, we did.
Because that is cannot be left behind.
Yes. That has been done. That has been very much under control.
You were using a drug which may not have.
Yes, sir, we have been doing that. We have been. In fact, I will just like to point out with everyone, we have negotiated with our radiologist. Radiation se negotiate ki zarurat hi nahi hai, sir. They negotiate with us. So what we do is we have now done a PET plus MRI package. So our normal PET scan will cost around 18,000 to 19,000 rupees. Because we are increasing the price, increasing the number of MRIs, we have put, and a normal MRI will cost around 8 to 10,000 rupees with contrast. Now a PET with MRI, because the number of MRIs are more, gets 23,000 rupees, 23. So we are now getting MRI done for everyone in lung cancer. अच्छा Ullas की नोट से चलो PET MRI होगा ही होगा इसका. So the number of things have increased, but we do MRI for every patient of lung cancer now, before surgery, after surgery, everywhere. By default it is that. I don't want to miss out on that nodule, because one small nodule comes over there, I will irradiate that. That is how aggressive we have become.
Just a question.
So,
you know, Sloan Catering prefers CT scan to PET scan.
So Sloan Catering has to have a reimbursement policy, sir. You have been there, a CT scan, you know, they don't do CT scans every 2 months and 3 months. PET scan is not reimbursed by the US government. A PET CT scan is much more cheaper over there for us. A CD chest, abdomen, neck will cost 17,000, 18,000. A PET scan will cost 19,000. We are happy getting a PET scan done, sir. I think we have finished that. It's all a question of costs and stuff like that, sir.
Yeah, but they said that their pickup, because they can regulate the CT slices, while the PET has only 32 slices.
Yes,
this thing, they have closer slices. So their pickup rate is better by CT scan. That's why they prefer CT.
That is right, sir. But I think most of the centers are doing a PET CT with diagnostic CT chest and abdomen.
I mean, I'm one of the people who've sort of propagated PET in this country from day one. I mean, to the hilt. But
also, last one. So these are 2 cases that I have. So there is always another way. And the third question which comes over here: 45-year-old male, never smoker. I think we have been stuck up at 45 only when it is a male, female. I think the slides were made yesterday at night, so similar thing was used for everyone. 45-year-old male, never smoker, stage 3 non-small cell lung cancer, CT/RT with weekly Backley carbo. What you asked, EGFR mutant, and PDL1 was 10%. I had to get AstraZeneca into that. So what would you do now? I will ask Dr. JP first. So what happens in your tumor boards? Will you consolidation durvalumab, consolidation TKIs, or follow?
I think yes, what's specific is the business, I think. Consolidation.
So my point over this again was discussed in WCLC this time, and they said adjuvant durvalumab in stage 3 NSCLC, and there is a concern. First of all, immunotherapy, I mean, as a rule, as a thumb of rule, it does not work in biomarker driven cancer. You can say whatever.
Yes.
And the second and the most important thing for me right now is, this is something which I have faced just now. We have a Pacific trial going on, a Pacific phase 4, that's okay. We have Pacific 8 trial going on in which we are comparing durvalumab versus a durvalumab plus an anti-TIGIT. Koi baat nahi, there was a patient who came, NACLC, we got a EGFR done, they only require EGFR, we only got EGFR. After 4 months of adjuvant durvalumab, the patient progressed. Happens, hota hai. We got the NGS done, ALK positive. We gave alectinib, and the patient got pneumonitis. I mean, my problem over there of TKIs after immunotherapy is that if you get pneumonitis, and I feel so bad, I take every death of a biomarker positive non-small cell lung cancer very, very seriously to my heart. I felt very bad on that. So you have no way. So unofficially what we do is we get an NGS done for everyone outside the trial. So it just costs, I mean, it's a question of volume numbers. It costs only 25,000 rupees or 30,000 rupees in our setup. And it's, I mean, the kind of people who come over there, we have research that's going on, people do get over there. So I do believe that immunotherapy should not be offered to a patient, who has a biomarker driven. It doesn't work. Second, once you have to give osimertinib again or alectinib again, after that you will have soup. So that is my point on that, sir.
Sure.
So this is the word of caution. I mean, I think, I hope, I am so thankful it is not a sponsored session by anyone. And so that I have been able to tell what exactly do I want. We want to discuss NSCLC options. I have a flight at 11:30. Okay, okay. Only the question, no, the better is the drama, no? So this is the stage 4 non-small cell lung cancer. Questions are no, entertainment is more important. So this is the EGFR mutant non-small cell lung cancer, and you have osimertinib, you have sequential TKIs, and you have TKIs combos followed by osimertinib. There are a lot of options over there. My subsequent reaction on a stage 4 non-small cell lung cancer is may the best man win. I mean, so I totally agree there is a place for everyone. I myself have spoken about dacomatinib and I have spoken about osimertinib. not yet spoken in detail about OC plus or erlotinib plus ramucirumab, but there's a place for everything. It's not, the truth lies somewhere in between. So you're absolutely right in giving first, second, third generation. So you have a 60-year-old female, we have made 60 because it's an old slide. Cough and breathlessness for 2 months, PET scan, adenocarcinoma. Now what I would want to ask you is, okay, this was a question about, I'll just show you my data first of all. I have again a big proponent of doing an NGS, as you said, for everyone. What we did was we had 490 patients on that, and what we did, EGFR and NGS. What we basically can find out is that there are 2.2 or 3% more people whom you will get EGFR mutations. Because remember, PCR may, you know what you are looking for. You have a Thera screen will pick up those 52 primers which you have. Cobas will pick up 29. If you do NGS, you will get more mutations. So 3% more mutation rate you will get only for EGFR, and NGS is the way to go. How we do is that, you know, we basically get a single gene testing done so that we have the report in 3 days time. We have an ALK single gene report in 2 days time, and then everybody goes for reflexly for NGS. So we don't miss out on any particular thing, and that's a panel that we have developed in our own hospital, and that's how it is working very, very well. And that's how we have again kept the cost also to much more lesser actually. This is something again which is very what I was telling yesterday. We also have seen the role of VAF and copy number again in EGFR mutant non-small cell lung cancer, again accepted for an oral presentation at ESMO Asia this time. This patient has got a, you know, somebody asked me about EGFR del 19, ALK negative, ROS negative, PDL1 90%. Does PDL1 have any role in EGFR mutant non-small cell lung cancer? And the answer is a vehement no. A lot of times people also ask me about, you know, EGFR पे osimertinib दिया था, उसका PDL1 90% था. Shall we give ABCP to this patient at that time? So you can give ABCP to any patient irrespective of whether the PDL1 was 0, 2, 3, 90, 100 after osimertinib. The magnitude of that benefit is something else, but just because your PDL1 was positive will not really change anything over there. And this is again what we basically saw, and this is also our own data. EGFR mutation and PDL1, this match is not made in heaven. This was our first paper which got accepted this year, and you know, people who had a PDL1 higher versus PDL1 lower, efficacy with gefitinib was not really very, very higher with that. Liquid biopsy in EGFR mutant non-small cell lung cancer, just running through this. We also have done a liquid biopsy in EGFR mutant non-small cell lung cancer, and we have got, this was a part of a thesis project by one of my residents, and something which Vijay was sharing very nicely yesterday. Give nice projects to your thesis students. Ultimately, you only benefit from there. And if you don't have money, apply for the ICON grant. ICON will be more than happy to support you with the grant. So what we did was we had Cobas and we had TheraScreen, and our liquid biopsy positivity rate was around 95-97% concordance rate. For that, we have hardly lost a patient on that. So, do you think, this is my last question, treatment of EGFR mutant non-small cell lung cancer with first generation TKI is suboptimal? This is Virat Kohli getting out. This is Roger Federer going. This basically shows you two things, that the slides were made yesterday evening, because this image only has been on Google yesterday morning. So these slides were made yesterday evening. But do you think, Dr. Shekhar Patel sir, how often have you used gefitinib or erlotinib in the last 1 year for stage 4 non-small cell lung cancer?
Still I am using that only, sir.
How much, sir? Has the percentage come down?
It has come down in selected cases. Still I feel...
How much, sir?
Maybe on 10% I can say.
10% lesser. But your workhorse is still gefitinib.
Gefitinib plus chemotherapy or
okay,
gefitinib.
Plus the chemotherapy. Vinayak?
I agree with sir. It's time to retire them, but there are implications not to do that.
Still, how much percentage of your this thing is gefitinib?
At least my perception has changed. I think I'm keen on everything.
Okay.
In practice, most patients cannot afford osimertinib.
So
and we end up using afatinib or...
KN regimen? You know the KN regimen, no?
Yeah,
PEM. The Kumar Narona regimen. This is what I famously called this as, you know, the PEM carb jeft regimen. Or you use afatinib, tacomethazole.
Afatinib or erlotinib.
Erlotinib.
Sir, it has changed. The use of gefitinib and erlotinib has come down, and commonly what I do now is we start with PEM carbo and we add that gefitinib if it comes out to be positive, and if the patient is affordable, then we shift to osimertinib. But yes, the use of dacometinib has also increased now.
Okay, I think a lot of things have changed and this is time for 10 o'clock, but I think there is a exciting times ahead for non-small cell lung cancer. I didn't want you to discuss about stage 4 non-small cell lung cancer. This is something which gets discussed every time. So, Dr. Chopra.
Just a word about, you can tell them about POSI and MOBO.
Yeah.
To complete the...
So just to complete, your exon 20 insertions also are very, very important. If you have exon 20 insertion, please do not give them osimertinib and afatinib and all. You have two drugs, one is amivantamab, which is there for first line, and you have mobocertinib, which is there, and you have poziotinib. Poziotinib is somewhere down the clock right now, but amivantamab and lazertinib, when we have a trial going on in the first line setting where we are giving amivantamab, lazertinib, plus chemo versus only chemo for exon 20 insertions. We also have a trial coming up for poziotinib in the second line. So, you know, these are exciting times ahead for that.
Only thing is, if anybody does use osimertinib, they have to use 160 milligram, not 80 milligram.
Fair enough, sir. We can discuss that later on that. With this, thank you. Thank you, panelists, for early morning firecrackers. Thank you. Thanks a ton. Thank you.